So to introduce myself for anyone that didn't know me that was listening, my name is Jaela and I'm one of the ID pharmacists at the VA. So I wanted to give this presentation that I'm calling Social Stewardship. That was something I came away with from IDWeek after going this past year. I went to the pre-meeting workshop for best practices in stewardship, and as well as some of the pro-con debates and other sessions on stewardship. I really came away with this theme of having a sociological or social behavioral approach to stewardship. And I was just really mesmerized by it, whether that's because I have a liberal arts background before pharmacy school, but I just found the concepts so interesting. They're, at surface value, very intuitive concepts and very commonsensical, but I think they tend to be less tangible to us as, maybe scientists or in the medical profession. So really over the last two IDWeek conferences in 2017 and 2016, there was a PhD, Dr. Julia Zimzak, who came and presented her research that she's done over the years in sociology on the social determinants of antibiotic prescribing. So I wanted to use this presentation to kind of condense a lot of those messages from IDWeek and see, what we can apply here and what we can use in stewardship. So I would say that my disclosures are, I do not have a PhD and I am not an expert in this. So this is going to be my novice attempt at translating some of this information from IDWeek. I also say that I'm an INTJ. So for those of you who have taken Myers-Briggs personality tests, an INTJ is definitely more on the thinking and rational side of things. So that probably makes me even less qualified to give a presentation on sociology.
I suspect many of us in infectious disease are INTJs,
yeah.
But I can only speak for myself.
Exactly. So as an INTJ, we're down here in the Sith Lord category. Where we would want to be if we were taking a sociology approach is probably more in the Jedi Master standpoint. So those who have maybe the F, like the feeling, aspect to their personality assessment are probably more qualified to give this presentation than I am. So we want to aspire to be Jedi Masters when we approach stewardship. So really, I call it social stewardship because it was a quick title or short title I could put on the schedule, but the full title is The Social Determinants of Antibiotic Prescribing. So how can we think of change behavior in social theory when it comes to changing the way people think about antibiotics? That takes into account the culture of your institution, your healthcare organization, the relationships between physicians and providers, as well as just cultural beliefs that people have about infectious disease. So it's getting, I feel like it's getting harder and harder to keep up with stewardship literature these days. There just seem to be new publications in every different medical journal that at least I follow. And so while social behavioral theory is not new, it's not a new concept, certainly not even within medicine, I found it really interesting that even across the last 3 months, I came across 3 different articles in 3 different journals that somehow related to social theory. I wanted to draw your attention to the one that was published in New England back in February. And it was just a perspective piece, so it's really short. I would highly encourage you to read it if you haven't already. But it actually has nothing to do with antibiotics. It was just about the psychology of clinical decision making. But I felt like it really set the stage for this presentation. So the author starts out by talking about some of the recent Nobel laureates in physics and economics and what we can learn from them in medicine. And he sets this idea that medicine is really a hybrid between science and social science. And if we can sort of better appreciate what goes into decision making, he kind of calls it like the wrinkles and twists of decision making. If we can better appreciate that, we can improve patient care. And so the idea is that when we are at the bedside, we tend to think that we're very rational actors. We persist in this idea that if we have all the information, we've done a comprehensive data collection, we've taken everything into consideration, assimilated it, synthesized it, that we're going to make the best decision or an optimal decision. But actually, we are disproportionately influenced by other things. So we're more influenced by information that's very salient and easily digestible and readily in front of us. And he says that's one of the reasons why pharmacy companies or pharmacy rep presentations are so influential, is because they have very simple messages and they're probably feeding you when they're giving you these messages. But in addition to that, we're moved more by the harms and losses that we've experienced more than like benefits and gains of treatments that we've seen. We also suffer from last case bias, so our beliefs are very influenced by recent experiences more than remote experiences, and that we tend to overestimate very small possibilities of things happening, like a rare adverse drug reaction, more than a beneficial, like larger gain. And so it was just really interesting that he just, really clearly lays out this dichotomy where we work in medicine, we come from this background of evidence-based medicine, so we think we're very rational when we approach things, but in fact, we're not. And so this was really echoed in every paper that I read preparing for this, and so I thought it was a good way to set up information. So I would encourage checking out that perspective piece. So what I want to do is define what it means to take a sociological approach to antibiotic prescribing as well as stewardship. What are the social determinants of prescribing, and how can we use this knowledge to inform stewardship? If we know that, what are the everyday barriers that we face when we try to interact with other colleagues for stewardship? And then look at some of the successful strategies that have already been used and published on change behavior with regards to stewardship. So everybody in this audience knows what stewardship is and what our goal is. We know that statistics say up to 50% of antibiotics are either unnecessary or inappropriate. So that's sort of what we're up against. So what I would argue is that it's one thing to just operate a stewardship program, and it's another thing to have a successful stewardship program. And so to sort of drive beyond operation and how can we be more successful, I think we really have to step back and look at what are the facilitators and barriers of appropriate prescribing. And then I always like to remind people, or just to appreciate what it means to prescribe an antibiotic, and that they're really the only drug that you could ever give to one patient where it could impact the effectiveness in another. All right, so winter is already here, actually. So the Joint Commission standard for stewardship has been out for over a year. And so hospitals across the country have already started to be surveyed against the standard. And so the Joint Commission is only going to expect more and more from us in terms of what our stewardship program is doing. But in terms of, what gives us regulatory structure to our program, this is the standard if you're not familiar with it. Good news is they already got rid of 3 at this point. So I think it'll come back. But I think they realize that trying to educate patients and families during an acute admission is more difficult to do than maybe programs are ready for. So what I want to argue about the standard and how it impacts what I want to talk about today is that educating staff and practitioners is a good intention, but literature tells us that it's not sustaining. When we do educational efforts, they usually don't have large sweeping impacts, and they're just not sustaining over time. And that using multidisciplinary protocols, policies, and procedures also is a good thing, and people want to make order sets and have policies, but we also know that people game the system. They work around IT, they can override policy. And so what I would say is that to take a sociological approach to stewardship really hits right here at the top. So making stewardship an organizational priority from the top down in their leadership. When we do that, we sort of internalize a new norm about the way that we approach antibiotics. And I would argue that if we make it an organizational priority, that is what can have wide sweeping changes. So why think of stewardship as a sociological endeavor? So one of the things that Dr. Zimzak did was present some of her research on interviews with different physicians. So this is an excerpt from an ID physician. So this was their perspective on why we should have a sociological approach. So, our hospital leaders are always looking for an IT fix. Let's have a pop-up box, or let's make it so the patient can't be transferred out of the unit until there's a stop date for the antibiotic. They're looking for this foolproof technological system. And that's important, but we really need to start focusing more on how we communicate this information, which is really not something we're trained to do or know much about. Stewardship has suffered from really heavy-handed mannerisms, like here come the antibiotic police. So we need to change that perception. We need to become great ambassadors. We just can't be nagging people, having clicking boxes and forcing pop-up boxes. We want to be able to empower and engage prescribers. So it's not about nagging, it's about good news, giving you great skills, making your life easier, empowering you. So we as physicians need guidance on how to engage and convince better to change behavior. So that's the why of why we need to have a sociological approach. So when it comes to behavior change, this was a recent systematic review that looked at a bunch of different stewardship studies that have been published and tried to categorize the different interventions that we have, whether that's education, audit and feedback, having restricted formularies, and prior approval. And so what we found is that audit and feedback is really the most common way that stewardship programs attempt to make interventions, and that's what we try to do here on a daily basis, reviewing Theradoc alerts, is we're auditing and then we're giving you feedback. So again, this persists on the idea that people are rational actors. So if we give someone enough information, we would hope that they would use that and make optimal choices. So for example, we could give someone 5 references on why it would be a good idea to consult ID in staph bacteremia because it improves mortality and so forth. And so it would be a very rational decision for someone to take that recommendation and consult ID. But we know there are times that they don't, right? That it doesn't matter what information we give them. They might have other reasons why they would choose not to take that recommendation. And so the conclusion really is that prescribing behavior is a complex multifactorial process. So how complex is it? So this is a visual for visual learners of that framework. So if you as a physician have a knowledge of ID, you know antibiotics and you know the patient. So you're ready to make a decision about using antibiotics, or you've decided that this patient needs antibiotics. So if we look at your perspective, what are all the things that influence that decision? So again, the healthcare system, social interactions, and cultural beliefs. Well, what if we wanted to take the patient into account and know what they care about antibiotics and what their perspective is? So if you get past all that, then you're ready to choose an antibiotic. Well, you have a plethora of availability of choices. There's not even the pharmacist's role on here. So do I even influence your decision making? So maybe that's where that comes into play. But so this is just a visual on the different influencers that go into prescribing behavior. So that sort of brings me back to Dr. Zimzak and where her research has really focused on sort of coming up with a list of social determinants of prescribing. And this idea that there are factors that drive our prescribing beyond just clinical knowledge or even medical need at the time. And so there's a lot of data beyond just antibiotics, but this idea that prescribing a drug is very much a social act just as much as it is a clinical knowledge act. So these are the 5 social determinants that I want to talk about: relationships between clinicians, patient demand, this idea of risk, fear, anxiety, and emotion when it comes to antibiotic prescribing, perception or misperception of the problem that we're facing with resistance, as well as environmental pressures that we all practice in. So relationships between clinicians, she sort of groups between the idea of prescribing etiquette, the role of hierarchy, and the opinions of senior colleagues. And so with prescribing etiquette, this really has to do with a physician's individual autonomy with decision making, and that within medicine, or probably most areas, there's this strong cultural, historic norm of non-interference. There's just not this precedent really of peer-to-peer feedback on prescribing. And so I think when, stewardship first starts out, we're calling you out of the blue or putting a note in your chart on someone that you did not ask for our opinion. And so that's this idea of overcoming, prescribing etiquette and norm of non-interference. Role of hierarchy is very important when it comes to relationships, and so we know that junior physicians defer to their attendings. We know that when we call people, we call the intern or we call the resident, more often than not we hear, well, my attending wanted it. And so with stewardship, we tend to focus our efforts on the junior clinicians while ignoring the relationships of their seniors. And so that's just something for us to think about if we are making new policies or trying new things. We really want to make sure that we have the buy-in from the attending level or the service chief level. And one of the interesting things with all this research is, very qualitative research, and so there's always a lot of interviews that take place, and so they all have these really great quotes. And so there's one quote from a resident that kind of captures this idea of hierarchy, as well as the opinion of senior colleagues. And he said that, whatever attending you're working with is who you learn from. And so if I see them constantly not prescribing antibiotics over and over again, then I would feel comfortable not doing it. But if they're always doing it, then I feel the need to do it. And so I think, we would all appreciate that. We learn from our mentors. And so if we want to change the way people approach antibiotics, we really should start from the top, top down from that. So patient demand. A lot of the literature about patient demand with antibiotics comes from, ER settings, AmCare settings, and even pediatric settings. I think, I can probably relate to this for our patient population. We can all maybe remember an SCI patient or SCI patient's family member who brought them in and was just convinced that their family member had a UTI. Just because, their urine has a different color, it has a different smell. And so they were demanding antibiotics. So patient demand is real. And, physicians might say that it just takes too long to explain that antibiotics are unnecessary. So if you have, someone in your office who has a viral respiratory infection, and they do, but they're sitting there in front of you demanding an antibiotic, it's just hard to make time to really go through why they don't need it. There's also some suggestion that clinicians may be overestimating this patient demand. They sort of always fall back on that excuse, but patients are getting smarter. The CDC does really amazing campaigns to reach out to the public to educate them on this problem of antibiotic resistance. And so there's probably a middle ground here where we can't just blame the patient all the time for demanding antibiotics. So again, there were some nice quotes from ER physicians and ER attendings this time on their perspective of patient demand. And one who's been practicing for 11 years kind of said that we as physicians have created an expectation in the population. They come in asking for antibiotics because the last 3 times they came in, they were told that they needed an antibiotic. So when they show up for the 4th time and say, I'm here for my antibiotic, we think that they're crazy. But in reality, we train them to come back and ask for an antibiotic. And the other physician actually likened antibiotic demand to opiates, which I thought was interesting. And so this idea that, they're probably very beaten down by patients coming into the ER for pain medication, they kind of felt the same way with antibiotics. So the physician is just so beaten down, they don't want to argue anymore with the patient. As much as they want to be the person to have that hard discussion and educate the patient, sometimes it's just really hard to do that. So moving on to the next social determinant of risk, fear, anxiety, and emotion. This is probably my favorite social determinant because it's just so interesting that we sort of have anxiety and fear with approaching infections and letting that drive when we prescribe them. And so this has to do with the perception that the risk of undertreating a patient will always outweigh an individual patient's risk from receiving unnecessary antibiotics. So some of the things that play into that is that adverse effects really have a limited impact on decision making. So a physician would be willing to risk giving a patient C. diff over just missing an infection. Broad spectrum antibiotics feel safe, so people sort of belabor under this thought that they feel safe. Whether or not they are is different. That doesn't matter, they feel safe. The overarching goal is just to prevent disaster in the next 24 hours. So when you're admitting someone, or you're on call, you're just trying to mentally get through the day. And so it's just easier to put someone on antibiotics than to think about it or risk missing something. And so really there's just emotional desire to provide everything to an individual patient without really kind of considering wider population consequences. So one of the things I wrote down from IDWeek was a perspective that you're not haunted by the cases where you did too much. You're haunted by the cases where you maybe didn't do enough and missed something. And so that's, I think, within the back of the mind of everybody, and kind of goes back to that we're influenced by our harms and losses more than we are by the cases that, you know, the patient did well. One of the suggestions I've seen on how to counter the fear of prescribing antibiotics is using peer comparison data, and it can be de-identified at the provider level. But if you're able to show in your hospital top performers, so people who don't overprescribe antibiotics, and if you're able to show that they have just as good clinical outcomes as people who overprescribe antibiotics, that can give some of those people who are driven by fear maybe more confidence that maybe I don't need to use antibiotics in every case because, physician X doesn't use as much as I do, and, they have just as good outcomes. So that's not easy to kind of put that sort of data together, but it's something that can get at this point. So some quotes, and these are more from residents, and it just really captures what I think we all know, that there are instances, where I erred on the side of caution and gave an antibiotic. If I was really anxious and thinking about that if I just give them the antibiotic, I'm playing it safe and covering. And in those instances, it was probably driven by fear. So when you're turning over a patient to, another colleague coming on for the evening or the weekend, you don't want to make it seem like you were undertreating the patient or you didn't recognize someone who was more ill. When it's 3 in the morning or 3 in the afternoon, depending on how busy you are, the easiest solution is just to throw vancomycin at the patient, at every patient, because you really don't have time to read all the guidelines that tell you 16 different things. And I think there's more pressure towards you're gonna look bad if you miss something and did not treat it appropriately versus giving C. diff or diarrhea, which is a little bit more anonymous. I thought that was really interesting, quite honest, and it's true. You're not necessarily the physician that sees that patient when they're on their 4th and 5th recurrence of C. diff. And so it is kind of anonymous at that point, who the initial culprit was for antibiotic prescribing. So perception or misperception of the problem, and the problem is antibiotic overuse and resistance. And so what they do when they send out this survey research is they usually start out by asking the physician, do you think antibiotics are overused? Yes. Do you think that resistance is a problem? Yes. Do you overuse antibiotics? No, definitely not. And so that's what this is getting at, that survey research finds that clinicians agree that antibiotic overuse is a problem generally, but not locally. So this idea of it's not me, it's others. Also that, if you're a physician who has never seen a pan-resistant culture, resistance then becomes more of a theoretical issue than it does something practical for you. If you have someone who has a pan-susceptible culture and we're telling you, well, don't use that antibiotic because it's going to have, further complications for other people down the line, that's not really practical to them because it says S, it's susceptible. And so it's getting people to think, beyond local and sort of accept those wider population consequences. And along with this is the idea of exceptionalism. So when guidelines don't apply to my patients are special, they weren't represented in those studies. When people use experience to trump guidelines, that's what comes into play here. And so in order to overcome this, we really have to try to make it more local to an individual physician and make it more relevant and tangible for them. And so finally, contextual and environmental pressures. So some of this was echoed in some of the other ideas as well, but time pressures, maybe in other places, not so much at the VA, but we have this pressure to discharge quickly. So that doesn't encourage let's wait for the cultures to return and de-escalate. If we have to get them out of the hospital, it's going to be maybe on an empiric regimen. We have competing priorities. So if a physician really only cares about patient satisfaction scores because that relates more to them in job performance, then they're going to be influenced by patient demand more than me trying to talk to them about antibiotic resistance. And time of day and decision fatigue is also really interesting. And so I wanted to show you this study that comes from AmCare. And so what they did is they looked at antibiotic prescribing in upper and acute respiratory tract infections. And so they grouped different infections into antibiotics that are sometimes indicated versus never indicated. So never indicated was things like acute bronchitis, flu, maybe non-strep pharyngitis, versus sometimes indicated was more like otitis media, maybe sinusitis, pneumonia, and strep pharyngitis. And so it was really interesting. They looked at the time of day as well as the percent of antibiotic prescribing. So even if we look at the bottom line on this chart, which is the class where antibiotics were never indicated. So even at 8 o'clock, 9 o'clock in the morning, when you're sharp and ready to go and have these conversations with patient, your antibiotic prescribing, 25% of the time, you're still giving antibiotics to people who didn't need them. But as the day went on, 10 a.m., 11 a.m., got closer to lunch, you're just like, whatever. And so your antibiotic prescribing increased in those patients who never had an indication. And kind of reset after lunch, but then it still kind of increased. And so this is, it's just really interesting. You just have to sort of internalize it and recognize it and be more, cognitively aware that this could happen in your practice. So the implications for stewardship of these social determinants is that, our interventions have been successful to a degree, but we could do better. We know that direct educational approaches generally don't result in sustained improvement. Restrictive policies really can be circumvented, so stealth dosing, waiting for the ID team to go home at 5 o'clock and then putting in your orders for Dapto or whatever you want, your carbapenem. Misrepresenting clinical information. So when physicians are being dinged because they're overprescribing antibiotics for bronchitis, they stop using the word bronchitis when they write their notes. So they try to outsmart the coders and the people who go back and pull those text words. This happens. It sounds terrible. And then combining non-restricted antibiotics to get desired coverage beyond what stewardship was recommending. So stewardship wants you to maybe de-escalate, narrow your coverage, or do something else, but they're going to use some smart combination of other antibiotics to still get what they want. So for sustainable change, we want clinicians to internalize new social norms. So antibiotics have this image problem. So we talked about broad spectrum antibiotics feeling safe, adverse effects being underappreciated. So that's the image problem of antibiotics. We also want people to be more open to questioning or being questioned about prescribing decisions, encouraging peer-to-peer comparison and feedback. And so if social factors can be considered in design and implementation of stewardship, we could have more research and more maybe tangible things to implement. So what have we talked about so far? So we talked about what it means to take a sociological approach to prescribing, and we kind of went through some of those social determinants. So what are the everyday barriers that we face? So that's kind of we talked about what goes into influencing prescribing. So then what are we up against when we try to have these conversations with others? So some of the everyday barriers in stewardship, and a lot of this information also comes from some of the talks that Dr. Septimus did at IDWeek as well. And so he talks about the misalignment of incentives. So we have different performance measures. We're trying to meet Joint Commission, OIG, CDC, whoever can give us performance measures. Well, surgeons have different performance measures, right? And the ICU might as well. And so we're speaking sort of different languages, or our goals have different alignment. There's a lack of definition of appropriate when it comes to antibiotics. So when you look at these different studies who've tried to put a definition or criteria on appropriate, they vary from study to study. And so who am I to go into someone's chart and use words like appropriate and inappropriate to describe their prescribing and make recommendations when there's really not a standard definition of that? Guidelines maybe. And then the lack of a standardized risk-adjusted measure. So, that's really our barrier in stewardship and ID, of having this lack of measure the way that maybe other disciplines do in their literature. The SAR, and if you're not familiar with that, it stands for the Standardized Antimicrobial Administration Ratio, is new and is the first measure that we've tried to have. It's not a perfect measure. There was a talk at IDWeek that asked, is the SAR ready for prime time? And the majority of people felt that it wasn't. And so it's not perfect, but it's the first thing we have. It allows us to compare our antimicrobial prescribing to other institutions of similar size and patient population. So for example, this is a graph that comes out of our annual report. And so it's showing you antibiotic days of therapy per 1,000 patient days. So at surface value, if I look at this report over the last 2 years, I can see that 2016 in the blue bars are antibiotic days of therapy, and over the last year, the green bars, okay, every month it looks less. So we think this is good, right? But to know what a days of therapy of 500 versus 400 is, it's not very intuitive of how to interpret this. So what the SAR does is it gives you a ratio of observed to expected antibiotic use, again, compared to other institutions of similar size and patient population. So if your SAR is 1, that's supposed to mean that your antibiotic use the observed use is maybe as expected. So if your SAR is statistically higher than 1, it could indicate excessive use of antibiotics. If your SAR is statistically lower than 1, it could indicate underuse of antibiotics. So I put our SARs on here for the last 2 years, and this is facility-wide data. It doesn't tell you whether or not that use is appropriate or not. It just tells you how you're doing compared to others. So it's kind of been described as a flashlight, where it could indicate something that you should maybe look into further. So this is just an example of another barrier that we face, is we don't have good standardized measures to really look at our antibiotic use. So I wanted to go back to that idea of definition of appropriate. And this was a paper in CID from last year from Johns Hopkins. And they did a study where they wanted to compare what was better in terms of a stewardship intervention, requiring pre-authorization of certain antibiotics, so always requiring a call to ID, versus post-script feedback, or that audit and feedback that we talked about. So I'm not going to go into the details of their intervention, but what they did was they adjudicated appropriateness in their study. And so they used a definition of this 4 moments in antibiotic prescribing. And so this was their criteria, was antibiotic therapy indicated in the first place based on known information? Was the most appropriate empiric regimen selected? Was it adjusted or reassessed or stopped at that 72-hour timeout? And was the duration appropriate for the infection? So I thought I really like this sort of laid out criteria, and I feel like maybe this is something that we could use. Anytime that we're considering an intervention, why don't we apply this criteria or definition to that to see if it, feels appropriate or worthy of an intervention. And then I wanted to talk about that misalignment of incentives that was mentioned as a barrier as well. So there was a pro-con debate at IDWeek that asked, should stewardship be done in the ICU? And it was really interesting. The person that they brought in to discuss the con side, that stewardship should not be done in the ICU, was a critical care pulmonologist. And so he laid out his perspective, and that really hits at the misalignment. And so he talks about, stewardship, you guys talk in metrics of DOT, drug costs, and C. diff rates. Well, we care about mortality, ICU length of stay, duration of ventilation. Your rationale for antibiotics is there's no evidence of benefit, de-escalate that Vanco. Their perspective is it can't hurt. Our action and responsibility from stewardship is you guys just sign the consult or you sign the note. We sign the death certificate. So I think it was, really playing the con side, but, I think that their point's well considered. He mentioned that the adverse effects of ASPs are really yet to be addressed. Are you going to own the cases when the patients don't do well after de-escalation? But really, his take-home was recommending that we just develop strong collaborative teams. So it's not a us versus you or us versus them mentality, but how can we make stewardship more of a collaborative endeavor? And then as well as talking about barriers to stewardship comes the different types of prescribers. And so I think this comes from Dr. Septimus's talk as well. And so he laid out these different types of prescribers: those who have a knowledge deficit, those who are insecure, and the outlaw. And some suggestions of how to maybe approach relationships with these different prescribers. So the knowledge deficit is generally the easiest. They're very open to those references that we put in our notes, mentoring, sharing education. Those who maybe are more insecure when it comes to their confidence level with prescribing antibiotics might work better with more scheduled conversations with them. Maybe it's not a note in the chart, maybe it's a conversation. Hand holding. If ID is on board, maybe they should just stay on a little bit longer through the end of treatment. Now the outlaw really feels that they have the best interest in their patients, and it's hard to imagine that someone else could have the interest of their patient in mind. They're usually the outlaw in more than one area of their practice. They may usually be in that insecure category, but not willing to admit it. And so these are the providers that you have to know their literature. You can't come up to them with what was published in CID. You need to go to the surgery literature, the vascular literature, whatever literature that they prescribe to, and know that inside and out, and come at them from that perspective. Acknowledge that you won't win every conversation, but you have to be willing to leave the door open for future ones. The outlaws, these are the ones you want on your committee. Using peer pressure, benchmarking, and risk adjusting might also help with them as well. We kind of talked a little bit about peer-physician comparison, and usually when we talk about that, it's de-identified information. But actually, I think Debbie Goff was the one who mentioned that surgeons are actually so competitive that it would work very well if you just put a posting in their locker room with all their names on it and their prescribing rates, and that would actually be very influential for them. I don't know if that's what they do at their facility, but I thought that was funny, I guess. So, strategies. So, what have people actually published on doing change behavior with stewardship? So one of the things that we want to do when it comes to approaching social behavior therapy is investigate the motivations of your frontline prescribers. take time to reinterpret your resistors. If your interventions are getting rejected, why are they getting rejected? Taking the time to hear what they're saying, why they want an antibiotic, and trying to come up with a plan together rather than just sort of, telling them what they're doing is wrong. Making sure to engage your senior physicians. Don't do drive-by ASP, ride along. That was a suggestion from IDWeek. So don't just, put a note in the chart and then never stop back in and see how the patient did with your recommendation. Stewardship is really about the trust that your intervention is for the best of their patient, and that trust builds with repeated interventions over time, engaging in those empiric escalations when necessary. Makes people feel like you're not just there to take off antibiotics, de-escalate, discontinue them. We don't really care. We care about the patient. It doesn't matter if, what antibiotic we're using, as long as we feel that it's the right one for the patient. So that is, engaging in those escalations when necessary helps build that trust. Some of the other suggestions was, making sure senior leadership attends your stewardship meetings, having an effective physician champion that can help with those relationships at the senior level within your hospital. They also suggest don't exclude ID from the stewardship process. So there's a lot of references that talk about how, as ID physicians, you're the role models for the other physicians in your institution, and that as stewardship, we really should hold you to the same standard that we would hold any physician in the hospital. And so I thought those were interesting suggestions, not to sort of silo, an ID consult service from the stewardship process. And then finally, they also talk about this idea of quality at the fringe, and don't chase bad apples. Don't spend a disproportionate amount of time on laggards, they say, or just people who are really so set in their ways, they're not going to change their behavior. So some data from people who actually know what they're doing. So this was out of JAMA last year, comes from the Dutch, and their problem was they wanted to tackle those resistors and this idea of tension between the governance of stewardship and the autonomy of individual physician prescribing. And so their goal was to use behavioral therapy to design and implement an intervention. So prescribers were going to choose and develop their own intervention, and they were going to do that based on a prior root cause analysis of their own patterns. And the rationale behind that was tailoring to local determinants. So having respect for prescribers' autonomy, that people tend to value a product higher if they make it themselves. And they cited something called the IKEA Effect. So if a prescriber chooses their own intervention, they're going to value that higher than me putting an intervention on them. As well as the idea that people follow up on something that they've made an active and public commitment to. So they did 12 months of baseline data collection on prescribing habits. They identified 4 themes of the root cause of inappropriate prescribing, whether it was the physician, the culture, the organization, or this idea of guidelines. And overall, they showed a significant increase in the appropriateness of antibiotics. And so this was just their cascade of the different themes and then the interventions that prescribers came up with. So for example, physicians felt that when it came to antibiotics, they had a lack of knowledge, inexperience, fear, and so some of their interventions were, participatory education sessions, maybe stand-up sessions to discuss specific cases, as well as supervisors promising to improve prescribing and support the guidelines. So using, senior physicians or attendings to set that model. So this was just a visual of their results. So you can see on the left-hand side, the baseline appropriateness of antibiotic prescribing was in the 60 to 70% range. At the time that the intervention was implemented, it jumped up to 80%, and it stayed relatively stable for at least the next 12 months. So an interesting data. So this is in JAMA a few years prior to the previous study, a nudging guideline concordant prescribing. So again, this comes from AmCare data, the problem being that in acute respiratory infections, half of antibiotics are prescribed are inappropriate for multiple reasons, all of which I'm sure we discussed. I thought it was very frank of the authors that they said none of the rationalizations for antibiotic prescribing were valid. And so the idea of a nudge is trying to influence decision making through subtle cognitive mechanisms, so like those Jedi mind tricks that we talked about at the beginning. So their intervention was a poster commitment letter in the exam room. The clinician had to have a photo on the letter, they had to sign it, and it had a commitment to avoid inappropriate antibiotics. So they wanted to take advantage of a physician's desire to be consistent with their public commitment. They found after they did this intervention, they had almost a 20% absolute reduction in inappropriate prescribing. Interestingly, they actually looked at whether there were diagnostic coding shifts, and they didn't find any. So that was good. No one was trying to game the system. And the rates of appropriate antibiotic prescribing during the period did not change. It was only reducing the inappropriate prescribing. So this is an example of that letter. I don't know that this is the one specifically from the study. I pulled this more recently from the CDC. But you can see that it gives you a spot as a physician to sign your name on it. So, this isn't really geared towards the patient. And so there have been studies that have shown that if you just put a poster in the exam room for colon cancer screening, that alone has no association that it actually increases a patient's, rate of getting colonoscopies. And so it's not so much that this public commitment is trying to decrease patient demand. It's really about empowering the physician to live up to the commitment that they've said that they would do. And so these ideas of public commitment have been shown to be effective in other areas like voting. If you say you're going to vote, you're more likely to, if you make a public commitment that you're going to vote, you're more likely to go do it. Fundraising contributions, and they even mentioned the hotel towel recycling initiative that we see. When people make public commitments to things, they're more likely to follow up and do it. Or I thought we could be like Europe and just tell it like it is. And so I thought this was just really frank and kind of in your face, but I've seen a lot more of these different posters coming out of the Europe for antibiotic awareness. And then the last article I wanted to highlight in terms of successful strategies was something I came across that, again, really didn't have anything to do with antibiotics, but it was about feedback and how to give effective feedback. And so they kind of grouped the types of feedback into different categories and gave examples. And so I thought it was still very translatable to everyday stewardship and making interventions. And so the take home was that feedback should be well designed, it should be regular, it should be actionable. So having a recommendation that is specific or gives something concrete. What do you want them to do? You're giving them a recommendation. I think that helps, those prescribers that are more on the insecure side. And that the feedback should be directed to the right person. And so I think, that kind of echoes, whether you're directing your feedback at a junior level member of the team versus, a higher level, depending on how the type of feedback that you're trying to get, being more conscientious about who you're directing it to. So my overall conclusions and take home, antibiotic prescribing is shaped by social factors more than clinical knowledge. If we ignore the culture of our organization and our hospital, it's going to decrease uptake of ASP interventions. We want to think how we can change perceptions, of stewardship, of antibiotics, be ambassadors, not police. Build trust, this idea of handshake stewardship, introducing yourself, building relationships before just sort of jumping in. It sort of made me think about when I first started here, and was doing stewardship even back in 2015, 2016, we didn't have a note title and we didn't have an encounter. And so a lot of the stewardship interventions we did at that time were verbal. We would have to, call the team and talk to them and have those conversations. And now it feels like we kind of live behind the safeguard of those chart notes. And so we do a lot more writing than we do actually verbal conversations. And so I think we probably want to maybe swing the pendulum back a little bit and try to have more, whether it's a face-to-face interaction or a phone call, because that's really how you build the relationship and you're not just a name in the chart giving recommendations on their use. If stewardship programs should really try to develop a plan for conflict, like knowing how you're going to approach those resistors. But when we can start to, think about it, do more qualitative research, in general, in ID and stewardship, hopefully we'll move to more like novel targets and interventions that we can try to implement. And then I just wanted to end with areas for future research and some of these discussion questions. If we have time, get your opinion, what you guys think about how to modify culture to change norms. How do we design interventions to target the emotional aspect of antibiotic prescribing? And what are some of the social behavioral dynamics that characterize an optimal way of doing stewardship? So thank you. I'll open the floor up to any comments, questions.